Interior Health would like to recognize and acknowledge the traditional, ancestral, and unceded territories of the, oh, I'm not on the seven.
Yeah.
You can be helping, we'll help.
Will you help? Okay, so someone help me with the first one.
Okay, the Dene,
Tanaha.
Yeah.
Good.
Nakba, Squatman, Statland, Silson, Colton.
Okay, thank you.
There's not gonna be a test on this one. is
No,
Yes.
no. Okay, so let's see if I can. True, yes. Okay, so just an overview of the services that we have, how you connect them. So a couple of years ago, mental health and substance use for Interior Health, they came out with a 310 number so that you dial a 310 MHSU, which is 6478, and your call will be routed to the community mental health center that you're calling from, whether it's a landline or a cell. When you call from Trail, it'll go to the Trail Mental Health and Substance Use Office. So instead of having a menu of phone numbers to call, just to call this one, and it will get you to where you need to be. And the offices are open from 8:30 till 4:30 p.m. Then there's the crisis line and the suicide prevention line. And then people can just come to, which was previously Cairo Manor and now Cairo Wellness Center, to access services. They have drop-in. You can go up to Kootenay Boundary Regional Hospital and see the crisis response nurse via the emergency department. Our outreach staff and team can connect. Other services can refer to mental health and substance use. Like we work closely with, as I mentioned before, child and youth mental health through Ministry of Children and Family Development, career development services. We work very closely with Freedom Quest, and the RCMP often refer clients, bring clients either via Emerge or to the center, but typically through Emerge. And then any of the local care providers, NPs, GPs, family physicians can refer either via fax, phone, or having the person come directly to the site. And then just an overview, we provide accessible care based on a person's individual needs. Their philosophy of care is based on individual goals and their definition of recovery. So it's not our program, it's their program. And we fit them into which column and what service is best for them. For people with moderate to severe mental health and substance use illnesses. So anyone with a mild anxiety, depression, that sort of thing can be followed by their GP or through various online programs, their employee family assistant program. We have Bounce Back, which is a telephone program. There's virtual services. And then moderate to severe is where someone whose functional ability is impairing their ability to go to work, to be an active member of their family. They're struggling with various issues, whether it has to do with a severe depression with suicidal ideation, newly diagnosed schizophrenia, schizoaffective disorder, bipolar, have been in hospital on a couple of occasions, and they don't meet the criteria for mild, then they would come to mental health and substance use, and we again would connect them with the most appropriate person. And then we go, we look after all people, all gender identities, cultures, ethnicities, and backgrounds. And we can see typically the first visit is an in-office visit if available, because we have to do an assessment for safety purposes. And if anyone is in a situation where they may be more aggressive or reactional to a situation, or we would have the RCMP join us, and then we would look at seeing people in their home, meeting them where they're at, whether it's in their home, in the alley, in the shelter, wherever they are at a family member's home. And then virtually, and then services can be voluntary or involuntary, and the involuntary population would be individuals who are certified under the Mental Health Act. They're on what's called extended leave. and they have certain conditions that they must abide by, or they would be recalled back to hospital if they don't meet those. And then there's, and then voluntary, most of our services, the majority, with the exception of those that are deemed involuntary that need to come for services, our services are voluntary. So people can refer someone else for services. We can go, we can meet with them, do an intake, offer our services, but if they refuse, we can't force those services upon them. We can encourage them, and we do multiple visits and outreach and introductions and strongly encourage them to participate. However, we can't force them. We work with multiple partners in the community, and we hold meetings on a regular basis. We talk about the overdose prevention services that we have to offer. Our OAT team, the opioid agonist therapy team, we have a nurse practitioner, as I said earlier, and she works until this Friday, and then she has resigned from her position, and we have Dr. Brian Garrett, who will be joining our team. And so they offer the prescribed medication. They are in the community, they are downtown in the alley, they are in the shelter, they are doing wound care, and Tammy works with a team, so the other team members would be registered nurses and outreach workers. Outreach workers would support them, taking them to appointments, getting them connected where they need to be. And then our nurses do, of course, the prescribing and the OAT and the medication, monitoring vital signs, and any of the wound care that needs to be done. There's a lot of education that's done with the clients. Anchors provides the drug testing here in the community once a week on Wednesdays. However, given the situation that's happening in Trail currently, with the recent number of increased overdoses that we've seen in the last week, Anchors will be here at the shelter this week, with the exception of Tuesday, but to do any urgent drug testing to see, because the drugs are changing on a day-to-day basis, and we put alerts out as well. We do intake appointments for individuals who may need more, or who are willing to have more services, and we offer what we can. There's peer support, and then of course any follow-up services. And like I said earlier, we partnership a lot with Freedom Quest, and they have outreach staff that work along with mental health and substance use. So this is just an overview. This is just similar to this sheet. We have Access, which is our intake worker. That's the first point of contact for anyone coming. Crisis response, again, is offered from the Kootenay Boundary Regional Hospital. We have we have two nurses, but the position is 7 days a week, from 7 in the morning till about 5:30 in the evening. We have a variety of counseling and treatment teams, seniors, mental health and substance use, early psychosis intervention. That is very exciting. That's a new position. And the individual, Trail will be the hub for early psychosis intervention. So this would be dealing with individuals, young adults, first break psychosis. So Trail will be the hub. We have a team lead, and she will start July 5th into her new position. And then we will be posting for a social worker and an outreach worker for Trail, as well as a social worker and an outreach worker for Nelson. And Trail will also cover the Castlegar mental health and substance use with this program. The treatment support and recovery team, that's our longer term clients. Youth ICM, as I mentioned before, that's a year in. We have 3 people, and we're very excited because one of the outreach workers on this team is a peer worker who's had lived experience. So she's really connecting with the youth. The intensive case manager program, we're excited about that as well. We have a new staff member starting on July 24th. She will mainly be working with vulnerable, unhoused people with substance use issues. We have life support outreach workers that work in all of our programs. And they do a lot of driving people to appointments, ensuring that they have ID, getting them, making sure that they're connected with a family physician, and if they're not, referring them to the new registry program so that they have medical assistance. And also starting July 27th, we will be adding a physician to mental health and substance use, and that is Dr. Tobias Galber, and he will be available once a week, if not more, to provide primary care to the vulnerable population. And Harbor House is a 9-bed tertiary mental health and substance use facility based just between the hospital and the ambulance station. And that program was initiated back in 2004, and that came out of Riverview downsizing money. And initially it was a 6-bed facility and then expanded to 9 beds. So individuals who have had frequent admissions to hospital that aren't able to manage on their own, with all of the support that mental health and substance use can offer to them, and they are still not managing, they can be referred through a process and obtain a bed at Harbor House, which is a psychosocial rehab facility. So they focus on life skill training, budget management, activities of daily living, such as showering and making a bed and grocery shopping, those sort of things to prep the individual. And that's, again, an adult program, 19 and older, and anyone length of stay can vary. And again, it's individualized, and it can be anywhere from 3 months to 24 months, sometimes longer. And then, of course, we have our inpatient psychiatric department, the Daily Pavilion, which is a 12-bed, a regional facility here in Trail. And then just the framework. These are our 6 priorities that guide the programs for the next few years, and we work in collaboration with various interior health portfolios, partner organizations, communities, using these priorities to transform our system and meet the needs of the people in the Kootenay boundary. So access, so ensuring access, easier access. So again, that 310 mental health and substance use phone number. Effectiveness, reviewing the effectiveness of programs, integrating standardized and evidence-based approaches, safe services, creating services for people who use substances by reducing the stigma and discrimination throughout the system. Primary care is a system about supporting enhanced integration of substance use care, treatment, and ongoing support into primary care centers, again, around youth. And I mentioned that, our youth ICM is a year old, and and then our intensive case manager that is new, and then of course Aboriginal priority there. Yes. Outpatient services. So of course the what is referred to as OAT, the opioid agonist treatment, and that is what Tammy McLean and her group of nurses and outreach provide. They provide the prescriptions for medication for harm reduction, and then again, they provide the case management. Intensive case management is coming. We have the substance use and counseling and treatment services, and then the continuum of services with youth who use substances. And then I'm not sure if council members here know, but there's a new program, and it's called the ICY, Integrated Child and Youth Program, and that is the provincial government providing funding for various positions throughout actually the school district 20. So we work very closely with school district 20, Ministry of Children and Family Development, and mental health and substance use. And there are about 6 positions that are coming in the future. So that is yet more services for the youth. And our safer use services, again, we have our outreach services, our overdose prevention and treatment, harm reduction, and a prescribed safer supply that people can access. I'm talking a lot. Does anyone have any questions, or do you want to save that till the end?
I definitely have some questions, but if we want to do it at the end, then we can kind of formulate all of them. Don't want to kind of interrupt the train of thought, maybe.
Okay, sure. That's great. So at the hospital, as I mentioned earlier, we have the crisis response team, which on a daily basis is one nurse, and she works very closely with the emerged physicians, as well as our mental health and substance use GPs that work on the daily pavilion. That's a new program that started about 3 years ago, that there is a GP on the daily every day of the week. And so in addition to the psychiatrists, there's also the family physicians that look after the medical care of the clients. Substance use connections, I mentioned her earlier, and then with our other team, and then the addiction medicine consultation services. We use our emerged doctors. They're all very comfortable with prescribing medications for clients, as well as our mental health and substance use GPs. And then we have a service that we can access for virtual addictions medicine, also known as VAM, and that is a call-in service that staff can utilize if they have a client that might benefit from the opioid-assisted or agonist therapy. So some of the programs that we're looking forward to is having a prescribed safer supply, also known as the fentanyl patch program, working in collaboration with a local pharmacy so that clients have easy access to that. Growing the addiction medicine consult service, expanding our partnership with Indigenous partners, substance use outreach, so enhancing that program with more staff. And as I mentioned previously, the intensive case management nurse role, which will start July 24th. And that is it for my presentation.
Counselor Hanson.
Okay, I have it, so bear with me.
All right.
So you said both the Harbor House has 9 beds and the daily has 12.
Right.
Are they fully occupied at all time, and should those be expanded for additional people?
So to the best of my knowledge, Harbor House is full at 9. And the daily typically runs over the 12 beds. It can go up to 14. So,
And is that in?
that's a very good question.
The capacity in the hospital is always fluctuating. So there are days when there aren't enough beds, and then there are days when the daily has 6 patients in it, the inpatient psychiatry unit. On average, the numbers would tell us it's sufficient. The challenge, of course, is that it's never steady. It ebbs and it flows. And so the teams work as best as they can to accommodate all the clients that they have and the needs. I think the area that we see the greatest need at the moment is adolescent psychiatry. It seems to be an area that's growing provincially, nationally. Can't say exactly why, but the demands for services of the adolescent populations probably are growing and most acutely. And that's a difficult population to work within it in the hospital because they're too young for an adult psychiatry program. And some of the behaviors that they exhibit make it a difficult fit in a general pediatric program. So it's a niche population that we need to find a unique care model.
Would our hospital have enough room to accommodate?
We think so, yes.
Do you want to go to other people, and then I can ask other questions, or do you want me to?
Sure, you go ahead, and then we can.
And so you said the crisis response team only works until 5. What happens after 5? The crisis is happening after 5. So he takes care of something 6 o'clock or on a Saturday or something, someone's having a breakdown. Is it just someone gets called, ambulance, first responders to the emerge, or is that to deal with them, release them? try to get them
Or admit, yes.
admit them, but there's not an active specific person on to deal with that other than whoever's at the age at that time.
Yeah, there's not a mental health crisis response program.
Okay. And the other thing is, I mean, if someone needs to go into detox, where, where is that? And getting them into a longer term treatment, what is the gaps between them? Because we've seen that there's been a lot of people that have gone into detox, come out because they've been waiting for a bed somewhere and then have a leave. Because there's been a gap between finding a permanent solution or back on the streets exactly where they came from, because there's a gap.
So what we have is Access in Castlegar, and that is an 8-bed withdrawal program, and the average length of stay is 5 days. It's a voluntary program. You cannot be forced to be there. People come and go at their will. Like once they leave, they have to be re-referred. It's male and female population greater than 19. And it is staffed 24/7 with a mix. They have an RPN nurse manager, with registered psych nurse, sorry, I'll try not to use acronyms, licensed practical nurse. And then they have withdrawal management workers as well.
So what happens between them being there and going to somewhere where they get a longer term or have an option to go to somewhere longer term for care?
So they would be connected with mental health and substance use if they wish that referral to be made
Mhm.
to mental health for follow-up, to carry them until they can access a bed at a treatment facility, and treatment facilities are out of the trail Kootenai Boundary region.
Right, and how long does that wait?
It varies, it depends. Some offer strictly male sessions and female, so they can take a little bit longer. It depends the choice of the individual where they would prefer to go. And again, like Daily Pavilion with the bed situation, they may get in quickly and there may be a bit of a wait. And so they would be held by their counselor and the team as best they could be until they're admitted.
Okay, thank you, Councillor Hanson. Councillor Martin.
You had your hand up first. Right. Okay, thanks. So, as you all, everybody's aware of the situation in downtown Trail has been going on for the last few years. How will this, as I just need what your thoughts are for the mental health and substance use services roll out for a temporary site that we might use for some folks downtown, and also more permanent supportive facility? How would that work?
Like having a downtown location.
Yeah, or just, what services would IH provide for those facilities? Just a question, that's all. Thank you.
Talked about that, and we're looking at sort of a hub concept, like having a downtown presence. And it was just in the initial stage now to have some primary care potentially. Our OAT service downtown, maybe our integrated case management team located downtown. Joanne, you can elect some of our outreach team, so that, because we know that even though it's just a hop across the bridge, that is a barrier for our clients. Some of the services we provide at the Cairo Wellness location, just people don't access because it's that far away. So we're looking at more of a downtown presence, and that's, I'm saying, initial stages.
Yes, yeah, we still need to meet with realtors, explore what space is available, and then work with our department in regards to within interior health, ensuring that places are up to code if they need renovations, that sort of thing. But it is on the radar.
Okay, thank you. Did that help? Did that answer the question about
I
what
think so,
services?
'cause- yeah, I think so. There's support.
There is, and support available, and there are different models that are being trialed currently in the province.
Okay.
The complex housing model is what I would say is the newest provincially. And there are homes now in Kamloops and Kelowna that integrate, excuse me, BC Housing with health. And there is a very intensive resource allocation to support those, healthcare resource allocation to support those who are living in community with mental health diagnoses. We don't see them elsewhere because they're still in a very prototype phase. But essentially what we have now is to step in and support wherever someone might be. There aren't necessarily boundaries to where the staff can and will go as long as the individual is consenting to care.
That's one more.
Sure.
Is there a, throughout the province, is there a plan or a set number that would be in these supportive, like permanent structures, like for number of beds for clients? Like, I know you don't want a large number, but is there like, what, 18, 20 or 30? Is there something that you would recommend once you start looking at that route, going down that road?
I think it's hard to say because everyone's needs are different. Some folks are just in the need of sheltering. They don't have the layer of living with addictions or a mental health diagnosis. So it's tough to say. The model that we're seeing introduced is small, handful of clients. That's it. Yeah. But these are folks who are at the, I would say the far end of the spectrum with respect to the severity of their illness that they live with and the amount of services that they require.
And your prototype isn't in Canvas, is that where they set up that complex?
And
And
Kelowna.
Kelowna, yeah.
Mhm. Yeah, the 6 people. Small.
Okay. Counselor, I have Counselor Benson, and then I've got you on the list, Counselor
Do you want to
Wilson.
go first?
Please go ahead.
I have 4 questions, but some are, I think, will be easy, but fast. So from the list, thank you for this handout. This is great. From the ones that are highlighted from your perspective, where do you think the gap is? Like, what could we benefit more from the highlighted ones that we
The ones we don't currently have.
because we at a conference we learned about the assertive community treatment groups that they have in Kelowna and Kamloops and what a success those have been, and just wondering if that's something we could advocate for.
What would be the end goal? What would you want to see as a result of the services? Because some of them have a different intent, and I think that might be helpful to understand, and then we can craft a response. Sorry, not to answer your question with a question that's so rude, but I think it's helpful for us. To
Well,
be able to-
the section that we sat in on was, is homelessness fixable, basically is what
Right.
and there was 3 things. 2 of them we have like more control over. It was about like zoning and things like that. And then the 3rd one was this assertive community. There's so many groups that are ACT or ACT in them. It gets a bit confusing, but the assertive community treatment has been really successful for, getting people back on their feet that are, unhoused.
So in my mind, having the intensive case manager program start with program 1 nurse. Start that and working with the same population, the unhoused, that may, she may become so busy at a point, we may need to expand the program. We're going to start with this, see how it unfolds, see the actual demand that is put on that program and move from there.
Okay, I like that.
Good.
And then with that,
May we add, we may have some other thoughts, if that's okay? Yeah, do you have some thoughts?
Well,
Karen?
yes, my thought really is, how to advance overdose prevention services, because we also need to, the more we can outreach and help prevent that overdose, the more we can develop comfort with moving people along a spectrum of care that suits them at their stage of readiness. And so in many places, the first phase for that is an overdose prevention site service of some kind. So, certainly Anchors has done a lot of work in the area, and I think it'll be, I know there is pop-up clinics here already, but I think there's an opportunity to.
My thoughts would be twofold. One, what we see, what's relayed to us from clinicians is that the change in the economy has changed the living circumstances for a lot of people, right? Fairly well known, which precipitates an anxiety, as you can imagine, being made homeless or sitting right at the the edge of being homeless. And that anxiety then feeds into addiction. And so often at our tables, we talk about the core of this is housing. The ability to support people is often predicated on stable housing. The ability to stop people from getting into a scenario of anxiety and mental health and addictions starts with housing. So that is a piece that, while it doesn't sit in the health realm, we see as a close fit for us between prevention and then supportive care ongoing. If we can't get people out of the situation that drives their anxiety, their paranoia, or their addiction, then we won't be able, putting them into treatment isn't going to change their trajectory.
Thank
So
you.
thank you for the prevention.
Yeah.
I think the more we can move upstream, the better we're gonna.
Treatment services are just in the moment.
Mhm.
Our goal is to think at 20, 30, 40 years.
Counselor Cashel and Mayor Jones and I did a tour of the current shelter with, Dr. Pollock on Friday. And we were able to go downstairs where there's, I don't know how many beds are downstairs, but it's a bit more of the same people use them. They're approved to kind of stay there. And I'm just wondering is there a service that goes to these people there? And there maybe you might have mentioned that, I just missed it, like, just, it's such a good opportunity because they're there. Okay.
Yes, so that would be our OAT nurses and outreach workers.
Okay.
When they do wellness checks.
Okay.
They work closely with the shelter staff, and a lot of the shelter clients are clients of mental health and substance use as well, and in the OAT program. So the nurses and the outreach would
Okay.
be visible there.
Okay. Can I ask a question about the current toxic drug intro? We saw the post from Tammy and the 35 overdoses, and is that 35 people or is that 35 instances of like one person
Good
could have
question.
had multiple?
So that is 35 instances where EMS was called to
Okay.
someone who's down with a likely overdose.
Okay.
So there were definitely some that were repeats, but most of them would have been separate.
Okay. Okay. And then my last question, sorry. Just thinking of just like our average, like local people, they've been through a lot with COVID and their businesses and they're getting pretty disheartened. And just wondering if there's anything, a lot of the small businesses don't have like an EFAT program. Is there somewhere that they could reach out to for just to talk about frustration or just, walk them through so I think once you put things in perspective, it helps a lot. Just to help with mental health for the average business owner that may not have EFAT as part of their benefit plan.
So they could phone mental health and substance use, and they would be seen on a short-term basis. In absence of EFAT programs, mental health and substance use would provide a service.
Okay. And that's the, has that written down?
310
Oh, that-
MF.
Yeah, 310 MSU.
NHS.
MHSU.
Yeah.
310-6478. Okay, thank you.
Yes, that's a good point. Through WorkSafe, if that business owner, there is a critical incident using capacity, I can.
Okay.
That
That would be awesome.
information.
Okay.
And then it's also the provincial units. Yes. To the toxic drug.
Okay.
Crisis. And basically what it is it's a provincial service that will come, they're mobile, and they will come in, and I think there's already a request going up for that. And I think that it would be great to include businesses as part of
Awesome.
it's called a response team.
Okay.
Mobile response.
Mobile
response team. You can look it up.
Okay, thank you.
Yeah.
I know we get asked a lot about it, just, and it's nice to be able to give someone a tool to go use, so, thank you, thanks for coming.
Okay, Councillor Wilson.
Yeah, just had two questions. You had mentioned it's a safe supply of fentanyl. What is that?
So it's a fentanyl patch program. And so the nurse prescriber or the GP prescribes a certain amount of fentanyl within this patch, and you wear it for, I believe, up to 3 to 4 days
Oh, it actually goes on your body.
on your body. Yeah. And then you go to the pharmacy, they typically have a room, they do assessments, they do vitals, they check how you're doing, response to treatment, and then the pouch would be removed, and then it has to be discarded very safely because of the fentanyl that remains in it, and disposed of correctly, and then another pouch would be reapplied. And so someone who is experiencing addiction and does not want to use the street supply would be given that, and it just sort of maintains them.
Gotcha.
Yes.
Would there be anything stopping someone from getting a patch and then going to a dealer and getting fentanyl? They
No,
could on their own.
They could,
Right?
absolutely, yes.
Just seems scary, that fentanyl.
Mhm.
The last question was, in your guys' opinion, what are we missing in trail? Or, you know, if you had a magical wand, what could we do to improve sort of what's happening there now?
Mhm.
It might be a loaded question, but if you had like a bucket list of 3 things that you think, I think we mentioned housing already.
Yeah.
But if there's anything else for
So my experience in communities has been the concern around the visibility of drug use, the visibility of the after effects of drug use, and individuals being in the community. And housing helps. We know predominantly people use in their home. That's the truth. It can be very unsafe, of course, because they may be using alone, but housing makes a big difference. And then the opportunity to have an overdose prevention site that I would say fixed is ideal, that is dignified, that is out of the view of the general public, because people who use want the same dignity and privacy. It may seem odd to say that when you consider or walk down the street, you can see what you see, but there are often people who would prefer to use in some measure of privacy. Those would be my 2.
housing and overdose prevention?
Yeah, I think for me, the third, and this is more challenging, is extended hours of crisis response.
Yeah.
But we know, you know, that as you said, right, crisis doesn't happen between 9 and 5 or 7 and 5. It happens almost at any hour of the day. The balance is finding the right time for people to be available and providing useful service versus having too much downtime. There is an element of the business model and what we have to do. But that would be the third one that I would say would be really helpful. And helpful, I think, to our police partners as well, who would rely on someone to call from a health background rather than taking them to the hospital.
Okay, I actually have a couple of questions. Councillor Cashel, if you want to go ahead, and then I'll put myself on the list, but you go ahead.
Thank you, Mayor Jones. Just following up on the previous speaker talking about the fixed overdose prevention site as being something necessary. Does the Interior Health have any plans, any concrete plans in place to implement such a service in our community? Thank you.
Short answer is no. Partly because the strategy that we've utilized has been reliant on interest and willingness of community partners. One, those can be non-government organizations that we partner with, the community sentiment, as well as city council, to be quite frank. There have been times where implementation has been easy, and I think it's pretty apparent in communities north of here where implementation of certain overdose prevention services has been extremely hard. So those become particularly challenging for us. So the strategy is developed and is community specific.
Thank you.
That's everything, Councillor Cashel?
Yes, Mayor Jones, thank you.
Okay, thank you. Okay, so I do have a couple of questions myself, and this goes back to the beginning of your presentation. And I think, Joanne, you mentioned that this area and surrounding area, we have 929 clients that access mental health and addictions at this time.
That is correct.
Now, is that an average number? I don't know how you would average that out amongst communities, but does that seem a little bit higher here than other areas that you work in, or is it?
I would say that's an average number. If we were to get the stats from Nelson, we would typically compare Trail and Nelson. So I think that is an average.
Pretty average. Well, I mean, I asked the question because we hear constantly that, you know, people are being brought in on the bus and, you know, in vans, and so I just thought I'd ask the question to clarify that doesn't, I don't know if that does happen when they come in bus loads, but if that's an average number, then that, you know, that's what we have to work with, I
And
imagine.
Mayor Jones, I can get stats from maybe the past 5 years and bring that information back and let you
Okay.
know if there's been an increase.
Okay,
Okay,
that would be great.
all right.
I just, also, I noticed that you, talked about an early psychosis intervention worker coming.
Yes.
And there was also the, talk of a new ICM position.
Yes.
And then also, you spoke about, 6 new, is that part of the 6 new positions that are coming to Interior Health in this area?
So those new positions for the ICY, the Integrated Child and Youth, that would be Kootenai boundary wide, those positions that are coming.
And those positions, just to add to that, are IHA will have funding for some, and so will the school district. So and so will the Ministry of Children, Child and Youth Mental Health Services. So it's going to be a collaborative. Those 6 positions will be divided up amongst those 3 service providers. School district, mental health, child and youth mental health.
And will those positions be based out of Cairo Manor, or will they, is there any new positions that will be in the shelter? I'm just kind of wondering if there's a possibility to get some kind of services in the shelter.
Okay, yeah, that ICY team is a separate, that would be with child and youth, but yeah, in the shelter, not at this time.
No, not at this.
And I don't know if you've had any conversations with BC Housing about a new consumption site in the shelter. I don't know if that conversation has taken place, or even if it's on your, okay.
You can.
Is that something, sorry, that BC Housing has indicated they have interest in?
You know what, I know it's out there. I know
Okay.
that, there, you know, was a discussion about it before, but nothing was really solid. Nothing was, you know, committed to. I just wondered if they had had the conversation with Interior Health. My understanding, Interior Health has to okay the consumption site before it can move forward.
The ministerial
There's a ministerial order
is not specific to that, I don't think, is it?
is there saying that overdose prevention services must be provided as emergency services in order to respond to areas of need. So I would say, yes, this is an area of need. And yes, we would support that. And sometimes what we'll do is we can write a letter of support, which often helps people who are trying to get an overdose prevention site work effectively with their community, with their RCMP and others in order to ensure the service is understood by everyone and systemic, you know, have some guidance that our harm reduction coordinators can help provide to the service as well to support their developing.
Okay.
Yeah, I'm not sure that there needs to be approval or permission per se, because that's given at a provincial government level. And,
Okay. Okay.
we would wish to be partners, as Karen has said, to offer equipment. Sometimes we're funding partners, and we have some expertise to support whoever is providing.
Yeah, referrals and services and actually.
Okay, just one more question. The VAM program, the virtual addictions and media, or for staff, that's just for staff to access for, no?
So the staff access that program for the clients and make arrangements for telephone appointments with the physician to have medications prescribed.
Okay, that's not something that,
If I'm an emergency physician and I'm seeing someone and like, oh my goodness, I don't know what to prescribe for this person's thoughts on something, okay? I'm comfortable with the thoughts on. I can call whatever it is and say, speak to an addiction medicine specialist and they can help guide me and say, if you want to start them on, you know, long acting opioids, here's what I would recommend, and here's the dosage, here's how you should follow them up. Here's a person I know in the community who can see them, that kind of thing. So,
Okay,
yeah, it's just.
Okay, that's-
Consultation.
yeah,
Yeah.
that makes a little bit more
Mhm.
sense, because you wouldn't want just anybody phoning up and being able to access that.
Yeah, and the family doctors can call as well.
Mhm.
Yeah, so now we encourage people to connect in with family doctors as well, and their doc, if they're uncomfortable, can access this.
Okay, sorry, I have one more question, Councillor Hanson. The Harbor House, you said it has 9 beds.
Mhm.
And it was created through the downsizing fund for Riverview.
Mhm.
Is that funding, has that changed over the years, or is that still the same funding that we received, you know, in 2004?
That's a great question, because we talk a lot about Harbor House and staffing model, even in regards to how it's initially set up. So, yeah, it's kind of a strong word maybe, but the funding at Harbor House is somewhat protected because of that stream where it came through the Riverview downsizing. So yes, in regards to the model, it's had increases over the years for the staffing model, yes. But generally, the model as it is has not changed. Like in terms of the nurse, well, we increased it to 24-hour nursing about 5 years ago, Joanne. So we do have a 24-hour nursing model that did change, but otherwise the life skill workers and the facility itself and the bed funding remains the same.
Oh. Okay. Okay, thank you. Councillor Hanson and then Councillor Benson.
So how many OAT nurses and outreach workers are there that consistently reach out to the unhoused population?
So we have a mix during the week, but typically we have a nurse on every day. It's not the same nurse. But we do have nurses on every day. Monday, we have 1. Tuesday through Friday, we can have anywhere from 2 to 3 nurses. And then we have 1 outreach worker every day. And then in certain situations, we can increase. For example, today, we were able to send a nurse and an outreach worker down to the shelter to support the staff and look in on the clients.
And one more question. Now, the treatment for mental health, is it all cognitive therapy approach, or are you guys using any sort of short-term psychodynamic therapy?
Great question. So it depends on the program. So for our short-term assessment and treatment, where we have the 3 master levels, they do individual counseling, they would do cognitive behavioral, they would do dialectical behavioral therapy, as well as we have 1 clinician that does the EMDR.
One service I don't know if we mentioned too is we do have a fairly robust, I'm going to say a very robust eating disorder program in the Cookie Boundary for youth and adults. With a clinician, MD, as well as, yeah, it's a good, yeah, I just wanted to move that to be aware for its youth and adult, because youth eating disorder is quite a issue.
Councillor Benson.
My question is gonna be, there's no like technical words. That's just gonna say, how can we help you? How can we help with this situation?
I'm curious about shelter and housing plans are in place and how we can be aware of those to enable us to services to planning that's going on for that, because I think that can really, speaking of term, I'm not a service, I don't provide the services, but I kind of had that big population health picture, so that's really helpful for us, and I do hear great things about housing plans here in Trail, but that makes me very excited because housing first, we know, is definitely, you know, one of the things that can benefit people the most for their health. That there's a lot of interest in including access to housing. I don't know the details.
Oh,
but
okay.
you know, what are the details? We, you know, we're curious and that really helps us plan our services.
That's a good point.
What have I heard? Well,
What?
I heard you're building.
Yeah, please. I hope so.
Okay.
I think softly, I would say these conversations help. There is so much misinformation out there
Yes.
about
100%.
what services are available and are not available, what we do and don't do, that it helps dispel the rumors and the myths and sometimes just bad information.
Yeah.
I think the other piece, and apologies for my tardiness today, we often can't compel people to treatment. The number of people we can compel people to treatment is so small. The Mental Health Act only gives us latitude in such a small segment of the population that the rest have to be voluntary. And there are a lot of people who think we should compel people. That's a conversation outside of this room at a different table. But again, I think this is really helpful. I think the other piece that would be helpful, I like the complex housing model. I think there are always opportunities when you sit with provincial government to voice interest and support. When the provincial government knows that there's municipal support, it shifts their perception of where they want to invest. It just does. And so if there is something of interest that you've heard about, helping to, I'll say lobby at the provincial table, goes a really long way. Because then it comes back to us through a different channel. So I think that's tremendously helpful.
Okay, Karen.
May I add one more thing? And I just think it's really helpful too when community is engaged and see people as equals. And so we know a lot of stigma and discrimination against people who have mental health problems or substance use problems can really challenge their ability to access services. So for just to all look not only at ourselves, which I've done a lot of, but also, you know, how our community is supporting people that likely have a significant history of trauma, particularly childhood trauma, through their life. And people are going to say, I chose to have this mental health. I chose to go to jail. Chose to be addicted to others.
Thank you for that. Councillor Cashel, go ahead. Oh, you're on mute.
Thank you, Mayor Jones. Joanne, you did touch on this in your reply to Councillor Hanson regarding treatment. So my question is this, does Interior Health recognize the need for a treatment facility in our region, in the interior? And that's the first part. And then the second part, if there is such a need recognized, is there any plan or any discussion around building such a facility in our West Kootenay region?
I would say yes, there is acknowledgement. I can speak for myself. I would say that there is a need. There is not yet a strategy that I've been made aware of with respect to expansion of treatment services, publicly funded treatment services to be specific. There's a number of privately funded services, which is different because you need to have the means to be able to access. So apologies that I don't have an answer for you. That's something I'd like to take away and provide after the fact.
Thank you.
There's also a lot of community-based services that doesn't necessarily people need to be in a facility. And I'm going to say for opioid addiction, that even holds more true because for alcohol, we know that detox can be really effective. A detox can be very dangerous for someone with an opioid addiction. So someone who's addicted to fentanyl or similar products, their brain has changed in a very significant way. And we detox them for 5 days at facility, and then they don't then they have access to drugs again. It's very easy, as we all know, who've tried to quit smoking or quit drinking or cut down. It's really easy to slip, and that slip when your body has dropped its tolerance for that opioid, may be the end of your life. So it's very dangerous. So I think we need to make sure we're having the right services at the right level for the right person, and making sure people are really wanting to do that as well, because as it has been said before, we can't force people into treatments, and we can only support them where they're at and help move them forward. So if we could change the drug supply, that would be outstanding.
Councillor Hanson, go ahead.
I just wanted a quick question. I suppose maybe it's my ignorance of mental health and addictions. If someone is not capable to make a decision based on their mental health and addictions to do treatment, how does that get determined? Because we're talking about they have to make the choice to go. But if they're not well enough to make that choice, how do you get them to a point where they are capable of making a choice on their own, or does someone else need to be able to be their power of attorney or their proxy to be able to say, you know, or if they're at risk to themselves with the Mental Health Act, step in at that point? Because I mean, someone can be fine today and, you know, or be not fine, and then they just show some sort of glimmer of, you know, of reality, I guess you could say, and then be, you know, the next day not. So if someone is not capable of making that choice, do they just get released? You know, do they just get, you know, sorry, you're here, we're getting help for 5 days, and now you're back out where you're gonna be, we'll put you in touch, and all of a sudden they were going to, now they changed their mind, or they haven't been able to identify that there's something issue. Like, how does that happen? How does someone get to the next step of care if they're not mentally capable to make that decision?
So I'm not a psychiatrist.
Sorry,
It's going to take 2 assessments by physicians over a period of time to make that, because it is a difficult thing to assess. It is easier. So right now, if you have, and it's so complicated, this is very complex, because people come in and they may have most likely both a mental problem and a substance problem are very complicated connected. So to tease those apart and to try to sort of what is the cause of this person's current mental state is very challenging. So that's done by a couple of psychiatrists over time, and they have to follow Mental Health Act, and that helps guide them to that decision making. Now, if someone chooses to use a substance and they can state that they understand the consequences of their behavior, then that's their choice. All of our choices to do that. If someone is clearly psychotic, can't make decisions, and are a risk to themselves, a risk to other people, or are deemed there's a few other things that I don't know from the top of my head that they're using to make that assessment, then they can be brought in, and the 2 physicians agreeing to that, held for a period of time for treatment against their wishes. And that is done in, they often try to reach out to families and get collateral information, and it's not just, so it's hard. It's hard.
What's tricky is it's the substance use that people often want to know more about, because the question is that behavior not destructive? Is that not, putting your life in jeopardy using a substance that might kill you? We don't see it that way in the health realm, because there's lots of things that we do that the general public does that is really risky, that is harmful to your health, but we don't remove your rights to choose to do that. And that's the rub is, and we don't always get this right in health. And there have been many audits that have shown that we don't get it right. We actually lean too much on we're going to take your rights away to take care of you. But when we look back and review cases, we learn that we didn't have the legal right to hold Mr. Jones or Mrs. Smith or Mr. Lee against their will. And so we're constantly walking this very thin line about how to make a decision that's in the interests of the individual and determine capable or not capable. So people get held for short periods of time, drugs clear out of their system, they are then capable, and then it is their right to choose to go into treatment, not go into treatment, stay voluntarily or leave. And that's hard. This is I think the real moral dilemma for clinicians to see that pattern repeated over and over and over again. And, you know, the desire to still help is there, and people aren't there yet. They're not there yet. And so I think the other piece is that it happens very stepwise. They go, it's not from here to here, it's small steps, very small steps to get people on that path to whatever the life they choose to want to live.
And I think it's important to note too that people also have the right to dispute their certification under the Mental Health Act. So if I was certified under the Mental Health Act, and as you say, I clear and I'm still certified under the Mental Health Act for some other reason, I can then ask for a review panel where there is a review done by a number of people, again, including professionals and physicians, where I can state my case as to why I should not be certified under the Mental Health Act, and you can be released from your conditions based on your level of wellness and how that's deemed with the board. There's a board.
If there's no other questions, I just have like a quick comment here. Councillor Cashwell's good? Okay. Well, first of all, I just want to thank you for coming here today. It was really important to get this information and, you know, maybe stop some of the rumors out there. I want you to know that if I can speak on behalf of City Council, that we're very committed to making a difference in the City of Trail. We have a lot of committed organizations out there, City of Trail employees, you know, staff members, community members, families that are working really hard to make a difference for people's lives out there. And I think we all understand the value of housing that we need at every level in this community, just to help with the addictions and just to get a safer vision for people that are living on the streets, right? City Council has been working really hard trying to understand this problem that we have in our community. We've done a lot of workshops. We've reached out to any organization that we can to get some better information and to educate ourselves so that we can help with the situation. We help out at events. We do everything that we can to make a difference. And I just want the community to know, and, you know, Interior Health, BC Housing know that we're working hard to get a solution, and this is all part of it. You know, meeting with Interior Health, meeting with BC Housing, having this conversation, it does make a difference. And no one has the answers to this. Like, this is across the province. It's across the country and the world. And we're just, like I say, working really hard as a team to help out here. So thanks again for coming. It was important for you to be here.
Thank
Thank you for having us. Yes.